Hi, everybody. Welcome back to Clinicians Brief, the podcast, where we have the conversations behind all of our Clinicians Brief content. I'm the host of this program, Dr. Alyssa Watson, and today I have the distinct pleasure of welcoming another brilliant veterinarian on our Clinicians Brief team. Dr. Jordy Waller is here with me today. We are going to be talking about an important topic. There was a recent article in Clinicians Brief that was entitled Top 7 Drug Classes to Be Tapered Before Discontinuation. And this turned out to be just a really popular topic. The article has gotten a lot of traction on the website. And so Dr. Jordy agreed to sit down with me, and we're going to kind of go through this article and talk a little bit about some of our clinical experiences with tapering medications. Before we jump into that, Jordy, thank you so much for coming on the show today. And if you don't mind, could you just introduce yourself to the audience? Just tell us a little bit about your background.
Yeah, you bet. Thanks so much for having me. Happy to be here. So, I graduated from University of Wisconsin in 2009 with my doctorate of veterinary medicine. And I worked for a few years in emergency practice in Madison, Wisconsin, and then jumped over into general practice, and now I'm in Seattle, Washington, and I'm working at a general practice in Burien, Washington, which is a little town just south of Seattle.
So, yeah, I guess I hadn't realized that you were a Midwesterner just like me. So I was born in Iowa, and I went to Iowa State. So good.
Very nice.
Yep. Yeah, a lot of good friends and colleagues.
Fellow Midwesterner.
Yep, in that area. So Minnesota, Iowa, Wisconsin, they all kind of stick together. I can hear the twang in your voice.
It doesn't take long before the Wisconsin in me comes right out. No doubt.
So let's talk a little bit about this article. As I said, it's the top 7 drug classes. We're going to be talking about 7 specific drug classes. But before we get into those individual classes, I kind of want to just take a minute to just kind of discuss, some of these reasons that we want to be tapering medications. The author of this article, really talked about these 2 main reasons that you want to be tapering medications. And one is to avoid physiologic withdrawal syndrome, which of course is kind of when, we have an exogenous drug that we're giving. And because we're giving that drug, we disrupt the body's physiologic feedback mechanism. And so then when we take that drug away, there's these adverse effects on the body. And then the second is disease recrudescence, or, the return of symptoms or clinical signs or the disease condition, when a medication is withdrawn. And those are the 2 big things, that we worry about when we have a medication that we don't want to stop abruptly. I feel like there's kind of a little overlap between them too. I don't know if you feel that way, but when I was reading through this article and when I was thinking about back on cases, some of the things do tend to kind of overlap a little bit. What are your experiences with either of these? Have you seen either of these things occur if you've stopped a medication too quickly?
Yeah, I think I can probably speak more to the idea of disease recrudescence, mainly because when it comes to tapering drugs, I'm probably really overcautious because I take the first do no harm idea really seriously. So I probably overdo it a little bit when I'm tapering medications, but I have definitely seen a few cases in my career where even with an appropriate taper, I've seen diseases come back. The first one, I had a dog that came in that turned out to have IMHA, and we got it under control and ended up being able to taper off both the prednisone and azathioprine. And the dog was doing great. And then it returned a number of months later, and it had developed not only IMHA again, but also ITP. And no matter what we did, we couldn't get it under control with drugs at all. And so, I ended up doing a splenectomy, and the dog ended up doing okay. But it just shows that, tapering too quickly can certainly cause these things to happen. And unfortunately, they can even happen when you've done what would be considered an appropriate taper. So, tapering drugs is a very important thing to make sure you're doing. Another case that I can think of where I wasn't aware that tapering was required, it was a little earlier in my career. Um, I had started using prazosin in my kitty cats that ended up with urethral obstruction. And one of the first cases that I used it, I sent the cat home on it for maybe 2 weeks, and then they ran out of it, which I thought was okay. And that cat came back in maybe a day after and was blocked again. So that was a really tough lesson for me to learn that prazosin is definitely a drug that requires some tapering, because you can have some like rebound problems if you taper it too quickly or don't taper it at all in that particular case.
Yep, that's one of the ones that's on the list of classes that we're going to be talking about later. So, yeah, I've had that too, and sometimes the tapering is out of our control because a client stops a medication without our knowledge. I think you're the same. I have so many drug labels that I have, written all over in capital letters. Don't stop abruptly. Don't stop. Call me. All of those things in order to try to prevent something like what you just talked about from happening. Talking about these two sequela, there was, when the author lists out these 7 drug classes, she really kind of talks about them from the stance of which sequela are we really more worried about? Are we more worried about physiologic withdrawal syndrome, or are we more worried about disease recrudescence? And corticosteroids were a little bit unique. They were the only class out of the 7 that she mentioned both. And so I was trying to think back, I've been in practice 21 years now. God, I'm getting old. And,
I feel
but
the same way.
I was trying to think back on if I've ever had, the two things happen, really simultaneously. But I assume it certainly could be possible. And just like you said, that ITP case or the Evans syndrome case is where I think I would really worry about something like that, not only getting some of those signs and symptoms from withdrawal of the corticosteroids, the body becoming dependent on them, but then also, just like you said, having those disease processes come back worse and not being able to get a handle, on them. I also had a case early on in my career that came to me that had been on both pred and azathioprine, both for years and years. And I ended up, I had talked to the owner, and I think I had called and talked to, an internal medicine specialist at the time about trying to get the dog off. And this was years. And every time we tried to taper, that dog, started to regress, and the hematocrit started to drop again. And so I think I managed that dog for a couple of years on both of those. And after a year or 2 years, the refills would just come through, and I'm like, yep, do it. He needs it.
Eventually you just stop trying. And I mean, it's, I've had cases like that where I want to take, a patient off of a medication, but they keep on getting sick every time you try. And I always tend to feel like I'm doing something wrong. But I do think that sometimes there are those cases out there where there's just really no option but to keep them going as best you can on the meds that keep them healthy. And, what else can you do?
Yeah. Another thing that I loved about this article and I found so useful was that the author was very specific about, some of these tapering schedules, and as well as, kind of these bullet point questions to ask yourself when you're tapering. you mentioned that you feel like you're overly cautious and you go with a very long taper. Sometimes that's not possible. I've had a couple cases throughout my career where the animal was having a really bad, side effect of the medication. I had a dog on phenobarbital, I remember, that had like a blood dyscrasia, and we had to get that dog off of phenobarbital quickly. And looking at some of the recommendations in this article, I might have gone a little bit too quickly, but there was nothing. Sometimes your hands are tied with that, and so those are the kind of the points that she looked at. So what are some, let's talk about some characteristics of the drug itself that we should be looking at when we're looking at dose reduction.
Yeah, absolutely. I mean, one of the things that one of the things that I learned reading this article, which I was mistaken on, it turns out, for quite a while. So half life is a really important factor to consider when you're thinking about how long do you need to take to taper a drug appropriately. Well, it turns out if you have a long half life, the tapering process doesn't have to be as long because the drug just stays in the body longer. So fluoxetine is a drug with a very long half life, and also it has an active metabolite with a long half life. And for years, I've been tapering fluoxetine very, very carefully in all my patients because I thought they would have terrible side effects if I didn't. But it turns out that fluoxetine is actually a drug that can be tapered quickly because the body is going to hold on to so much of that drug just based on its half life. So that was a great point that I learned from this article.
I also find that just the formulation of whatever drug you're looking at is helpful when I'm trying to come up with a tapering schedule. Certainly, I find liquids so much easier to taper. I always find if I've got pills, especially, I mean, corticosteroids just come to mind over and over because there's so many different indications for them, right? We could be dealing with allergic disease, we could be dealing with the autoimmune disease, so many things. And so, but oftentimes I'm like, oh, I'd like to reduce that dose by 25%, but that's, a quarter of a pill. How am I supposed to do that in this patient? And so, just even having something like a liquid formulation where it's easier to taper and you can taper in smaller steps, if you need to reduce by 10%, because some of these tapering schedules that were listed out, were reducing the dose by anywhere between 10 and 25%. And then, waiting anywhere between a week to even a month, 4 weeks between, the step downs. And so I thought that was really helpful as well. Anything else that you thought that struck you or you found really useful in that first table?
Yeah, I mean, I feel like one of the things that was useful in the table, a thing that needs to be considered is, some of these patients that have chronic diseases, they're on drugs for years. And, for whatever reason, at some point, they, need to be that drug needs to be discontinued. And they need to be switched to something else. And certainly, the length of time that a patient has been on a drug has to play into how long you're going to take to taper that same drug. And so I found that to be a really useful idea that, if you think about it, if you've got a patient that's been on, phenobarbital for 5 years, you're not going to want to taper that drug off over a couple of weeks if you can possibly help it. You're going to want to do that over like 5 or 6 months, probably, so that it can be a safe process.
I think piggybacking on that too is how many drugs are they on for this particular condition. That was another thing that they highlighted. If you're on 6 or 7 is a lot, but 2 or 3 different immunomodulator drugs, in order to control that immune mediated disease, you might be able to safely do a little bit more rapid taper because you've got those other drugs, in the system coming at that from that multimodal approach, and hopefully, stopping that disease, those clinical signs from recurring. So that was another one. And then what else? I know, disease severity, right? That was one,
Yeah.
like how bad is it? Are we talking about atopy, and yeah, they're going to get itchy and it's going to be annoying, and we might get some secondary infections, or are we talking about something like your case where we might end up with life-threatening Evans syndrome and need our spleen taken out? So
Yep. Yep. Absolutely. And yeah, and in fact, that dog that I removed the spleen, I did keep. I just if we already took the spleen out, and then what else can we do if this disease process comes back? So I kept that dog on a low dose of prednisone for the pretty much the remainder of its life. And I mean, uh, that dog ended up transferring care somewhere else, so I don't know how it all turned out. But that dog was well for years. And yeah, certainly a case where, if that IMHA or ITP came back, we're going to be extremely limited in how we're going to control it.
so that kind of leads really well into the first drug class. The first drug class on the list is corticosteroids, and we've talked a little bit about it already. I loved the fact that the author broke this down with suggested taper times depending on, how high your dose is, as well as how long you've been using it, because obviously if I'm using steroids for artitis, that's going to be a week, or, maybe 2 weeks at the most. Whereas, some of these other indications, I've got animals on steroids for months or longer. And so the having that guidance when we're using steroids for those shorter courses was really helpful to me. What kind of experience do you have? Do you usually have those patients on shorter courses of steroids, or are you using them longer in practice?
I would say that far and away, I tend to see cases where I'm using steroids, uh, anti-inflammatory doses, in short courses. I would say that you know ears and skin and that kind of thing are kind of the bread and butter, probably, of any general practice. So in those cases, put them on a steroid for a couple of weeks, do a quick taper, and no problem. Thankfully, immune mediated disease and such things tend to be less common, and always make me more nervous because I'm using what seem to be really high doses, and I'm using them for quite a long time. And obviously worry a lot about side effects in those cases and what the consequences are going to be when you start to decrease the dosing. And so yeah, far and away, I'd say itchy dogs. That's pretty much the main purpose for steroids in my practice.
Yeah, I think we're in agreement there, but it's nice to have that resource, for those cases that you see a little bit less frequently. Um, the author also talked about, non-corticosteroid immunomodulating drugs. So yeah, things like cyclosporin, azathioprine, mycophenolate. So what did you take away for best practices, for tapering those, and what monitoring strategies we should be using?
Sure. I mean, I think the main point that I took away from it is, you know, usually when you're dealing with drugs like this, when you do go ahead and taper them off, most of them don't have a physiologic withdrawal syndrome associated with them as much as a drug like prednisone would. And many times you are dealing with a disease process that you're controlling with multiple drugs. And so, in a case like that, you're also, with tapering one of maybe three drugs, you're not going to be quite so worried about the disease rearing its head again when you do taper that drug. Um, and so, typically not as life threatening of a situation if you are dealing with a serious disease like IMHA.
Looking to protect your canine patients against parasites? Look no further than Simparica Trio, Serraline Moxidectin and Pyrantel chewable tablets. The first chewable to offer triple protection from heartworm disease, ticks and fleas, and roundworms and hookworms. It's also FDA approved to block infections that may cause Lyme disease by killing deer ticks.
Use with caution in dogs with a history of seizures. Serraline belongs to the isoxazoline class, which has been associated with neurologic adverse reactions. The most common side effects were vomiting and diarrhea.
Visit SimparicaTrioDVM.com for full prescribing information.
So the next class of drugs on the list and that we're going to talk about is anticonvulsants. And I would say secondary to corticosteroids, this is another drug that I use really frequently in practice. I have personal experience, a couple different personal experiences with having to take animals off of their anticonvulsant. When I mentioned the bad reaction to the phenobarbital, I also actually had a case early on in my career where I had a pair of dogs in the same household that had been put on anticonvulsants, and they had actually been misdiagnosed, probably through no fault of the clinician. It was just a funny story. It ended up, I finally got a video of these dogs because the owners kept saying they were having breakthrough seizures. And by this time we had them on 3 different anticonvulsants. And these dogs were actually having reverse sneeze episodes. And so and they had been on anticonvulsant therapy for years. But it always makes you think, when an owner comes in and says something like, "Oh, my dog's having seizures," it's good to just take a step back and, actually have them describe what they're seeing at home. It was a very valuable lesson that I learned early on in my career that, you have to, sometimes tease out a little bit more of these details. So I did end up having to take both of
Absolutely.
those dogs off of anticonvulsants, 3 of them, 3 anticonvulsants each. And so one of the things that really surprised me in this article is that there's really a lack of evidence-based, recommendations for dogs and cats. We extrapolate a lot of things from humans, but I was a little bit surprised by how little information there is out there on how quickly, or what could potentially be the negative consequences if we taper too quickly in animals on anticonvulsants. And so I don't know, how about you? Do any cases come to mind where you've had to stop an anticonvulsant?
I have a little digression related to the case that you were just talking about where the patients weren't actually having seizures. When I was in vet school, there was a dog that came in and the owner said that it had been having seizures, and they brought it in on emergency. And the person that brought the dog in himself was actually a human neurologist. And we were taking a look at this dog, and it did appear to be convulsing, but it was also kind of screaming. And we eventually sorted out that this dog was experiencing pain from an atlantoaxial subluxation in its neck. And it was having painful episodes where it was kind of flailing around and all these things. And so to your point, it's really important. If anytime I can get somebody to send me a video of episodes that their pet's having at home, because people all the time say, I think my cat is coughing, or I think my cat is trying to get up a hairball. And it's it turns out that cat was coughing and it actually has asthma. It wasn't trying to get up a hairball, things like that. So just a little digression there related to your story. But yeah, I guess the other thing for me is I don't think I've ever had to take a dog or a cat off of phenobarbital because of adverse effects, but I have had to do a dose reduction in cases where I get blood work back and the phenobarbital level is too high. And I haven't had too much of a problem getting those back down without big problems. I don't think I've ever tried to reduce the dose more than maybe 25% at a time to get those drug levels back, into under control. But certainly it's important to just do it slowly.
Another key point is that there aren't really many recommendations for when we're using anticonvulsants for other purposes, which, we do a lot. When you really think about it, that's what gabapentin is, right? Gabapentin is an anticonvulsant, and I don't use it for seizures ever. I use it for, analgesia, and I use it for, anti-anxiety. But I think aren't there other indications for even like phenobarbital too, like cellitis or
Yeah, that's true. I don't know. I've never used it for that, but I definitely remember seeing it in a drug book somewhere. I also had a colleague that used it for a dog that needed really strict activity restriction after an orthopedic surgery, and the dog just seemed to be refractory to everything we were trying to give it that was a normal, like, sedatives type drug like acepromazine or gabapentin. So that dog was put on phenobarbital, which worked beautifully. And, in that case, the dog didn't have any pre-existing seizure problems. And so, when the activity restriction was lifted, that dog was tapered really quickly off the phenobarb. And there were no, ill effects from that. But certainly that was an unusual usage of the drug.
Yeah, absolutely. And not something that I would have thought about, even though I know phenobarb is a taper drug. If I was using it for something besides seizures, I'm not sure my mind would have gone there, and I would just be like, oh, just stop it. So, so just something, things that stood out to me that we should all keep in mind.
Absolutely.
Let's see. Another class of drugs that was brought up was proton pump inhibitors. Okay, so things like omeprazole. I don't use a ton of these. I probably should use more than them. I'm sure I see a lot of like esophageal related disease that these animals could be benefiting from PPIs, but I haven't used them a lot that way. I do know that at least on the human side, there are some concerns with long-term PPI use. I don't know if that translates over to our canine and feline patients or not. I had a client once that the one time I did want to use PPIs, she refused to use them because she had read something that they cause, stomach cancer in people. And so she absolutely refused to use a PPI in her dog. So I can certainly imagine, that there are reasons that we might need to come off of them. And certainly it's very well documented that with long-term use of PPIs, you can get this rebound, gastric acid secretion, if you taper them too quickly. So, what factors do you use them a lot, or what would you prioritize if you needed to get an animal off of a PPI?
Yeah, so I would say that my experience with PPIs is usually more short term, dogs that have like, the classic, garbage, eating situation where they've got a really sour stomach. Not so much of a long term situation, but what I do know is that I don't know what the evidence is for dogs and cats as far as the side effects that you get for long term use. I don't know if it's comparable to humans, but I do know that if you use them for a long time, it actually changes, the structure of some of the cells in the stomach, and it makes the acid producing cells of the stomach bigger, and they make more acid. And so if you take away those drugs, very rapidly, you end up with this huge load of acid being produced in your stomach. So you end up with a pretty sick dog and a pretty uncomfortable dog, I would say. So certainly in those cases, it's important to stop it really slowly, over, a matter of months to prevent that sort of rebound hyperacidity.
So that brings us to our sympatholytics, which, you had given your little story earlier, which was a great one. So, in these drugs, are we primarily worried more about the physiologic withdrawal or the disease recrudescence? It's so hard for me to say that word, recrudescence. I don't know why. Recurrence.
Recurrence is so much easier. I actually practiced recrudescence in front of the mirror for like an hour right before this. So just kidding. I think that, with, alpha and beta adrenergic antagonists, you can probably see both. Disease recrudescence and physiologic withdrawal. With physiologic withdrawal in particular, though, if you have a patient that's on one of these drugs, like a beta blocker, like atenolol, for example, if you withdraw it rapidly, you can end up with reflex tachycardia because all those receptors that you've been blocking in there are suddenly hypersensitive and they're very reactive. So that would be a really good one to taper slowly as well. But also, if you have a disease process where you require a beta blocker and you just stop it, I mean, in a worst case scenario, you could end up in a situation where you're ending up in heart failure. So certainly important with those drugs to remind people to get their refills on time and try not to skip any doses.
Yep, another one that gets a big alert right on the drug label from me, don't stop, certainly medications for hypertension too, I'm like, don't stop this suddenly because we can get some pretty severe rebound hypertension if we don't taper those drugs accordingly.
Absolutely.
The author did talk about opioids, which again, I thought the discussion about opioids as well as the very specific, this is when we need to be thinking about tapering opioids if you've been giving them more than 2 weeks. I think 2 to 3 weeks was what the author said. I don't prescribe a lot of opioids, although, for a while there, the tramadol was the big, drug that everybody was handing out. And so definitely I've had patients, while I don't prescribe a lot of tramadol anymore, I still will reach for it in certain cases. But I still have patients, come to me that they've moved or they've switched veterinarians and they've been on tramadol for years and years and years. And I might want to try maybe something else, especially I went through the whole switching of tramadol from a non-controlled substance to a controlled substance, during my time in practice. So that might have been when I stopped prescribing it quite as much, or it may have been, the studies that showed that it just, didn't seem to do what we had hoped that it did for dogs, at least. And so anyway, I thought that was really helpful, talking about, the opioids and, when you need to consider tapering them. What types of adverse effects are we looking at when we stop opioids too quickly in these patients?
Yeah, the main side effects that are seen when opioids are stopped are going to be GI related. So you can see some vomiting, some diarrhea, and the other side is neurologic. So some of these pets will come in and they'll be shaking or tremoring. And it brings up a good point of like, when you see a dog coming in like that, even if you did maybe do surgery or something, a couple of weeks ago, it might not be on, front of mind that, this could be a result of opioid withdrawal, or at least it wouldn't necessarily cross my mind. So I think it's a good reminder that it's important to look back at drug histories in the chart. It's important to, really talk to people about, when was the last time you gave X, Y, and Z drugs to your pet? Because it sometimes these things are a result of withdrawal symptoms. And if you can identify that, it's a lot easier to make these patients comfortable.
Yeah. Or tacking onto that too, I've had clients that, they had a prescription for a pet that passed away. And then, they had a dental or a surgery or something like that. And they perceived their animal being painful, and they were the same size. They didn't call to check. And so it can be news, if you don't ask, you're not going to know. And so, because I definitely have had that situation where I've had clients, sometimes a little sheepishly, sometimes with, they had no idea that it could possibly cause a problem, say, oh yeah, I was giving Fluffy's tramadol that I had left over from 3 years ago.
Mm-hmm. I think we've all had those moments of like, really? From 3 years ago? Okay. I might have made a different choice. But, desperate times call for desperate measures, right?
Exactly. Well, I can sometimes I need to step back to and have a little empathy and put myself in some patients in my client's shoes. I've got, they're about 9 months old now, but we got 2 puppies around Christmas time at the exact same time. And I will tell you, there were some nights, especially with, getting into the trash or diarrhea or something, where I was that person. I was just going through the medicine bin. Like,
what do
I have? I don't care that it's from 4 years ago.
Yeah, precisely. So. That is, I think we've all been there at one time or another, haven't we? Absolutely.
Yep. So the last class of drugs that the author talks about is behavior modifying drugs. And just like you, that fluoxetine thing blew my mind. But it makes sense, right? It makes sense that a drug with a long half-life, is going to stay in the system. And just like you said, fluoxetine is metabolized into an active metabolite that's still in the system. And so you don't necessarily need, a long taper like you would with some of, with maybe some of these other behavior modifying medications. You think about serotonin reuptake inhibitors and things like that. Those are ones that I often am pretty careful with. And just to be on the safe side, I say, let's go ahead and taper slowly, as long as the animal's not experiencing severe side effects, or, I don't want to get them off quickly so that I can get them on something else,
Yeah, absolutely. And I don't know how I missed the memo on the fluoxetine. I feel like they really drilled that one into us. And I even thought about it at times. Like, it's kind of funny that we have to taper it so slowly because it has such a long half-life. But then I never really looked it up. So, man, that just, it's like, hello. That came as a surprise. For certain. But and I would say that for the most part, fluoxetine is the drug that I grab off the shelf the most often for, behavior cases. A couple of times I've used clomipramine, or I've had a patient transferred to me that was put on clomipramine by a different vet. And, the withdrawal symptoms of drugs like that in humans can be quite severe and very unpleasant. And so I do always try to be really cautious about doing a really slow taper, because as we know, they can't really communicate with us to let us know how it's feeling to be taken off a drug like that. So we want to do it so that it can be, not a terrible experience for these dogs and kitties.
Yeah, we're taking them off the medication, so hopefully they can feel better, or we can get them on something that's a better fit for them, Yep. Absolutely. So Well, I've loved sitting down and talking to you about this. I really liked this article. And so I was really happy that somebody else on the team, wanted to just kind of sit down and chat about it. And hopefully our audience found it really useful as well. You can check out the article for yourself. It's on our website at www.cliniciansbrief.com. And so that brings us to the end of the episode. And I know you had some questions about what is rapid fire. Rapid fire is a little game that we play at the end of the podcast episodes, and it is just for fun. They are would you rather questions. There's no right or wrong answer. It's actually something that our audience really enjoys. So will you play with me, Jordy?
I will play with you, but I do want to remind you that I am a veterinarian, and so I am, I really want to perform my best here, and I really did want to prepare in advance, but
type A personality, and I wouldn't let you. You're like, what is it? I'm like, I'm not telling.
All right. This is way outside my comfort zone, but I'll do it.
Okay. All right. First question. Would you rather spay a fat dog, or would you rather extract a carnassial tooth with a slab fracture?
Gonna have to go with the slab fracture on that one.
Oh, really? I'll spay the fat dog any day. I'm not a teeth person.
I've gotten more comfortable with the teeth over the years.
Yep. Oh. Okay. Do you abbreviate subcutaneous SC or SQ? I said there's no right or wrong answers, but there's actually a right answer to that.
I know, exactly. I'm like, I think that technically I should say SC, but I definitely don't. I use the SQ.
Team SQ over here. Awesome. All right. Would you rather place a catheter in a dehydrated kitten or an obese bulldog?
Ooh, I'm gonna go with the kitten on that one.
Okay. All right.
Go with the kitten.
Confident.
I think that I might be the cat whisperer at my practice, so I would pick the cat any day.
Yeah, I honestly would go with the kitten too. The bulldogs, it's just so much skin.
And also the fact that you're going to get a lot of drool on your hands while putting in the catheter. I mean, it's a whole extra challenge.
All right. If you were at a party and just talking with a group of people, would you rather have to explain male nipples or imitate the sound of a reverse sneeze?
I think I would go with I'd go with the reverse sneeze. Mm-hmm. Yeah, talking about male nipples just makes me way too uncomfortable.
And yet we've all had to do it,
Yes, we have. I know. It all comes up eventually.
Yeah, it does. That's not a tick.
Yeah. Do I have time for a quick digression on that one?
Of course. Absolutely.
Do you
have a good that's not a tick story? Because I feel like every veterinarian has a good that's not a tick story.
Well, this is a story about me making a real bonehead of myself. But when I was in vet school, I was examining a young little male dachshund dog, and I'm looking at this dog, and then I got real serious, and I was like, I'm going to step out for a minute. And I went out to the clinician that was overseeing our rotation, and I said, I think that dog has a bunch of tumors. And she went into the room, and she was like, yeah, Dr. Waller, those are nipples. Those are nipples. I'm pretty sure I just went home then. I was like, I'm going to go and recover from this experience, and I will be back tomorrow.
I will be back at it.
Yeah. So anyway,
I'm
nipples,
sure that
they fooled me.
Yeah. Like I'm sure that nothing's coming to mind right now, but I know I've had horribly embarrassing situations and things and made obvious mistakes that I was like, what on earth did I just do?
Happens
All
to the
right,
best of
last
us.
question. This
Okay.
question, and this question is in honor of our wonderful producer who I love so much. But would you rather have all of your support staff talk in movie quotes, nothing but movie quotes, or Taylor Swift lyrics?
Oh, movie quotes, hands down. I'm a movie quote aficionado. So
All right,
I'm the
excellent.
one at my practice that's always talking in movie quotes all the time. So yeah, I could definitely get behind that.
I think that that's awesome. Although you may have just been uninvited from the podcast forever because our producer is a huge Taylor Swift fan, and shout out to her because she's actually going to be going to the concert in London next week. So, but
Wow. Well, see, this is why I wanted to know in advance what this rapid fire question thing was, because I didn't want to give any bad answers, and look what happened. So
it's not a bad answer. Actually, it's like I'm a movie quote person too. I love, and I the most random ones. And my poor staff, a lot of them are, as I mentioned earlier, I'm old now. And so I throw out these movies and people have no idea what I'm talking about, and then I just get depressed. So
that happened.
No,
to
you
me
did fantastic
every
at
day.
rapid fire. I loved it. I had so much fun. And I'm just kidding. You are absolutely welcome back anytime, any day on the podcast. We love having you.
Great. Well, I had a great time, and yeah, I would even do rapid fire questions again if I was invited back.
One of these days, I think when we have repeat guests, somebody should flip the script and do some rapid fire questions on me. I don't know what I would do. I'd probably freak out.
I think that that's a very good idea, and we should do that real soon.
Okay. Well, I just want to say thank you to our Clinicians Brief audience. I hope that you found this discussion helpful, and we'll see you next time.
Thanks again.
Thank you for joining us for today's episode of Clinicians Brief, the podcast. If you enjoyed this episode, you can find us wherever you listen to your favorite podcasts, including a video version on YouTube. While you're there, make sure you subscribe, rate, and review us. You can also listen to or watch our podcast episodes on our website at cliniciansbrief.com/podcasts, or drop us a line at podcasts@vetmedux.com. Clinicians Brief the Podcast is a VetMedux production, produced by Alexis Ussery and hosted by Dr. Alyssa Watson.